So meanwhile, we're just waiting for our some faculty and students to join. I'll just give a brief introduction about Dr. Meenakshi S. Ma'am has been my teacher at Sankara Nethralaya, and she's a very distinguished, very senior pediatric ophthalmologist and strabismus specialist. So we are really happy to have her join us today. Welcome, ma'am.
Thank you, Neena. Thank you for having me. You know my love for teaching, so I'm so glad to be part of your grand rounds.
So we are discussing three cases, two cases of strabismus and one interesting cases of night blindness in a child. So we'll start with our first case, which is the fallen muscle and the rising eye, the strabismus saga after orbital trauma. Be presented by Dr. Trisha Yadu.
A very good morning, all. So we'll be starting with our first case, who's a young lady, 26-year-old. He has a history of road traffic accident 5 years back in 2019. He has had multiple surgeries in the left eye after that accident. And now he presents to us with binocular vertical double vision, which is increasing in downwards. So reviewing his medical history, in 2019, he sustained road traffic accident, after which he had left eye orbital floor plus medial wall fracture with orbital contents herniating into the floor defect, along with anterior maxilla, zygomatic arch, and multiple facial bone fracture. He underwent reduction and internal fixation for the same elsewhere. Now, in 2020, this patient had an ophthalmos for which he underwent floor reconstruction with titanium mesh elsewhere. In 2023, his orbital rim reconstruction was done with peak implant along with titanium floor, medial wall implant, nasal osteotomy, zygoma and arch reconstruction. Now, 2 months after this peak implant, he had methicillin-resistant Staphylococcus aureus infection, for which implant removal was done and the axis was straight. Now, this patient presents to us 2 years after the implant removal. This is his external and facial examination. On external examination, he had a left head tilt along with orbital dystopia in the form of enophthalmos, hypoglobus, lower lid entropion, lagophthalmos suggesting partial facial nerve palsy, along with infraorbital paresthesia and corneal sensation reduced in all the quadrants, suggesting multiple cranial nerve involvement. On ocular examination, his best corrected visual acuity in the right eye was 6.6N6, 6.9N6 in the left eye. Pupils were normally reacting to light. Color vision was within normal limits. On squint sensory evaluation, he had a stereopsis of 400 arc seconds on Randor, and for distance on Worth 4 dot test, he had diplopia. This is a 9-gaze ocular motility picture of the patient. In the primary gaze, we can see he has left hypertropia, along with -2 elevation limitation in the same eye and -2 depression limitation, and also -1 abduction limitation in the left eye. We went ahead and did a cover test for him, which revealed 18 present diopters of left hypertropia in the primary gaze, which was increasing to 25 present diopters of left hypertropia in the left gaze and also in down gaze. And for near he had 20 present diopters of left hypertropia. This is the patient's view of diplopia charting, in which we can see in primary gaze he has crossed diplopia, which is becoming uncrossed diplopia in the left gaze, as well as vertical and horizontal separations are increasing in the left gaze, also in down gaze. We can also see some intorsion in the left eye. So we did a PARC 3-step test for him. The left hypertropia was increasing in left gaze, also in right tilt, which was suggestive of inferior rectus palsy. We did a force duction test, which was minimally tight for inferior rectus, but force generation test was negative. Also, downward saccades were poor or floating in nature, which was suggesting a mixed mechanism of strabismus, paralytic as well as restrictive. We did an imaging for him, which revealed right inferior rectus was coursing inferiorly into the region of the floor, and left inferior rectus, is coursing inferiorly into the region of the floor, and is visualized for length of 2 centimeter, and it was entering the region of previous fracture. Also, the inferior rectus fibers were appearing to be partially avulsed at mid-dorsal. So we advised to go ahead with the orbital flow repair, and the possibility of worsening of the squint post-operatively was explained to the patient. The orbital procedure was done in form of entropion correction along with fracture flow repair with patient-specific implant and release of intraorbital contents from the fracture site. The fracture flow was noticed 3 mm from the inferior orbital rim, coursing to the mid-orbit almost till apex. Now the patient presents after the orbital procedure, and as expected, his hypertropia in the primary gaze in the left eye has increased to 35 prism diopters, and it's increasing more in down gaze now to 15 prism diopters. But his elevation in the left eye has improved, unmasking the inferior rectus palsy. So 2 months post-orbital flow reconstruction, our plan was to do a FDT. If the FDT was positive, we'll go ahead and recess the superior rectus with the inferior rectus tightening. If the FDT would be negative, we'll do a horizontal rectus transposition to inferior rectus. So on table, the FDT was found to be negative. So we went ahead with horizontal rectus transposition to inferior rectus with augmentation. So using a conjunctival limbal peritomy, the lateral rectus, inferior rectus and medial rectus were identified. The lateral rectus was hooked, secured by a sutures at its insertion, and then disinserted from the original insertion and reattached 2 mm away from the temporal margin of the inferior rectus in the inferotemporal quadrant and secured at the sclera via sutures. Again, the medial rectus was identified and disinserted and then reattached in the inferonasal quadrant 2 mm away from the medial margin of the inferior rectus, and augmentation was also done at 8 mm. So now the patient presents to us 1 week post this procedure, and in the primary gaze we can see his hypertropia has improved to 6 prism diopters, and his elevation limitation has improved to -1, and depression he still had diplopia in the down gaze only, which we managed with 6 prism diopters based on prisms in the left eye. The patient did well with prism glasses. On Worthford test, he regained fusion with prism glasses. Now our second case.
Dr. Meenakshi, ma'am, would you like to ask any questions? Or should she proceed?
Yeah, so I was just going to ask you, what is the format of the grand rounds? Can I ask questions? Because, and the audience, I'd like to know if there is a mix of postgraduates as well in the audience.
Yes, ma'am. We have more of DNB trainees and DO DNBs with us. Trisha is a fellow, of course.
Right, right. Very well presented, Trisha. So if you don't mind, I'll just go through the presentation so that there are some good take-home points in this case. Very beautifully managed case. So very, very tough case to manage. So I thought it would be nice to go through some of the points because the second case, as you had sent me a short summary, is fairly more straightforward. And so if you, Dr. Trisha, can you go back to the initial slides, the very first beginning ones? And are the postgraduates in a position to answer, or shall I just only speak? What is your suggestion? Neena?
No, you can ask, ma'am, if you want. If they are not able to answer, you can add on.
Okay, all right. Okay, so this is great. So the thing to remember, even as even if you're a trainee, and soon after your training, you're going to become a consultant, you're going to be seeing patients like this. Especially if you're going to be an oculoplastic surgeon. Marianne, I know Marianne very well. So it's you are going to see patients. So remember, the patient is very emotional when they come to you because they've already had a bad accident. They've had multiple surgeries. Now, on top of it, now they're seeing double. And he's a young guy. He's 26. He's got his whole life ahead of him. And, he probably is never going to be able to drive a two-wheeler again, or at least he's hoping that he can, when you're done. So remember, a patient like this has already had multiple surgeries, has been to many doctors, has come to you with a lot of expectations, is likely to be emotional. So number one, when you see this, take time. Remember, block some time and say, I'm going to spend some time with this patient, talk to him and find out his concerns, his hopes, his aspirations, his regrets, etc. So I'm going to do that first. Okay. Go move on. Go into the next one. Yeah. You can tell that this is a really, really bad fracture. So the postgraduates, when you see a CT scan like this, clinically, what is going to be the most prominent finding? And if the postgraduate is okay, I think this is going to be cumbersome. I'll just keep talking. So when you see that so much of the orbital contents has just gone into the sinus, this patient's going to have very little stuff remaining in the orbit. So he's going to have enophthalmus. So remember that that's a big cosmetic blemish. And so that is something that is going to be bothering the patient as much as the diplopia, etc., etc. Enophthalmus. All right, go ahead. You can, yeah. So that's what they addressed. All right, go to the next one. Go to the next one. Yeah, and as you can see here, the enophthalmus is still persisting, and the entropion is very clear. Here, you can see the entropion very clearly. And that I think Trisha has also told us that there is lag of thalamus. So,
Yes.
And there is less corneal sensation. So what is your number one concern when you're going to bring this eye down? When you're going to bring this eye down, eventually, your concern is your whole life, the patient is going to have to lubricate that cornea during the day and at night. Because right now, with the partial lag of thalamus, he might be, most of the cornea may be getting covered. But once you bring the eye down, and I know the entropion was addressed, but once you bring the eye down and with the lag of thalamus, there is going to be corneal exposure at night. And remember, he's an IT professional. And so he's going to be staring at a screen, blinking less. So ocular surface concerns is something that you're going to counsel him, tell him, boss, you're going to have to keep that cornea lubricated the whole time, right?
Yeah.
So you have to look at the patient from so many angles. Okay, go ahead. Right, so that's what she already said. Yeah, go ahead. I want to see the 9 gaze. Yeah. So, Trisha, can you point to, in this photograph, if you didn't do the 3-step test, which is the gaze that tells you the inferior rectus is just not working at all? Which is that?
Yes, ma'am.
Which is
yes,
the
ma'am.
gaze?
So left hypertropia was increasing.
No. Just point to the gaze that where you can see the IR is not working at all. No.
Ma'am, down gaze.
Yeah, down gaze. Where does the IR, the inferior rectus, work the most? The next one. Levo depression. Go down one more. There. Compare that. Postgraduates, remember, compare that with the other side. Can you show the other side? Inferior rectus. The arrow, can you take the arrow to the other side, inferior rectus? There. Compare that inferior rectus with the other inferior rectus. The other inferior rectus, the affected side, is like -4. Right? Because when you examine patients and do ductions and versions, you have to isolate that particular muscle and see and where it's acting the most. So where it is exclusively the muscle that acts. So for the inferior rectus, in this particular case, levo depression, dextro depression is where it is the only depressor. In primary gaze, what are the two depressors? Trisha, what are the two depressors?
In primary gaze, ma'am.
Right. Yeah. What are the two depressors, generally speaking, in primary gaze?
So you have the
inferior rectus and superior oblique.
And also oblique.
And superior oblique, correct. So when you want to isolate the inferior rectus and see, hey, is it working or not? You have to take to that gaze down and to the left and down and to the right. Okay. Okay, move on. You can go on to the next. Yeah. Keep going. Right. And that, can you point out, go to the diplopia charting, and can you point out that particular field where the diplopia is the greatest, the separation is the greatest? Excellent. Remember, the diplopia charting is like as if the patient is looking, right? So you can see that that is the separation where it is the greatest. You can see both horizontally it is more, and it is vertically more, and you also get the torsion, right? So all this already tells you, hey, you know what? I think I'm dealing with an inferior rectus weakness, or inferior rectus is not working. That is your working diagnosis as you are moving. Yeah, go ahead, please. Yeah, this was good. Please go ahead some more. Yeah, and I want to pause right here and say, the little bit of surprising thing for me here was that the FDT, but you would do the FDT here for which muscle, Dr. Trisha? Which is the muscle that you're most concerned about?
So, ma'am, when the patient still has hypertrophy in the primary case before the repair of the fracture, so we'll be assessing the inferior rectus.
No, see, anytime you have a hypertropia, the eye is high, has been up there for a long, long time, which is the muscle that's going to get tight?
Yes, ma'am. The biggest muscle, the superior rectus, will be tight.
Right. You can do the inferior rectus. I'm not saying, because it is possible the inferior rectus is, enmeshed in that mess that is there. There is the titanium, there are some implants, there is some tissue, there's a fracture. Absolutely true. The inferior rectus can also be tight. But right here, your focus is going to be, hey, when something has gotten weakened, then how is the antagonist, right? And here the antagonist is the superior rectus. So we are going to look at superior rectus for tightness, and you're going to see how is the fourth generation test for the inferior rectus, because you want to know, hey, when I examine the patient, the inferior rectus doesn't seem to be working at all. I've isolated and seen the patient in that gaze, and it's just not working at all. And my 3-step is also saying it's the inferior rectus palsy. Okay, but I want to know whether there is any function left in it. There is no function left in it. So, and this is a very, very important point there, which is the downward saccades. So that is, suppose you have a child, you can't go and put one, hold a forceps and start shaking the eye, right? So in such patients, you want to know whether in a tactile way, can you do something? And that is the downward saccade, where you ask the patient to look straight, and then you give another, target down. Quickly, they move from the primary to the downward, primary to the downward. And then you see whether the inferior rectus, that is the downward movement to the affected eye, is as brisk as the other eye. And so that will tell you whether, there is if the inferior rectus is palsied, is dead, or whatever it is. Okay. So great. So this tells you, because there is minimal tightness for the IR, it tells you there is a mixed mechanism. Excellent. Go on. Right. So, yeah, go on. Because there's other interventions happened here. And then, yeah, please go on. Okay. So, Dr. Trisha, why do you think the hypertropia got worse after this intervention?
So, ma'am, that was the whole thing about this presentation. That initially we were suspecting that there is some restrictive component to the inferior rectus as well. So, after the flow repair, that inferior rectus was relieved, and hence the restrictive component was also relieved. So,
Absolutely.
the unmasking of the inferior rectus paralytic component happened. Hence, the hypertrophy in the primary case in the left eye increased.
Right. So the inferior rectus was always palsied. I mean, you shouldn't pretend. Right from the beginning, the inferior rectus is kind of dead, right? So, so this just tells you that the restrictive component that was there, you have freed it up. And now you have a kind of a pure palsy, if you will. Okay, now you can really, really. So actually at this stage, you have to repeat everything again. Ideally. So to know, hey, how much is the downward saccade? What has happened to the superior rectus while all this orbital, treatment was going on, etc., etc. So you should actually repeat everything once more before you embark. I think, go on. Almost done with this. Right. So the rest of it was very, very beautifully managed. And I mean, I'm so proud. Dr. Neena is my once upon a, I even, I'm a little shy to say student because they're all so big these days, but I'm so, so proud how beautifully this was managed. And so when I went through the thoughts, when I went through the presentation, I had some thoughts and I just wanted to share some of them with you. Remember that when you look at the scan, and when you sometimes see that the transected inferior rectus, it's very tempting, especially if you have a good orbital surgeon colleague like Marianne, it's very tempting to say, you know what, I'm just going to go in there and just stitch the two halves together. It's not going to happen at all. Don't even bother, okay? Because as quint surgeons, we are not used to working in a tiny hole way deep in the orbit. And if you can't even visualize when you're, and it's going to be bleeding, because I've done these kind of things a few times. But when you go in there and you just no way you will be able to suture in that hole as well. So it's actually dangerous. So you have to have a backup plan and say, you know what, I am not going to go and do all this heroic things, heroic surgeries. I'm going to take the help of other muscles. That's what other muscles are there for. Okay, Dr. Trisha, I have a question for you. So you did the beautiful surgery has happened, an inferior naps, as sometimes we would call it, transposition. But if this patient was, say, 50 years old, what would be your biggest concern when you saw this patient in terms of safety of the eye?
Yes, ma'am. So, in elderly patient, we'll be looking at the risk of anterior segment ischemia as well.
Absolutely. Can you explain to the postgraduates why that is? Why anterior segment ischemia is a big, big concern in this particular patient?
So, ma'am, in the elderly patients specifically, if we operate on more than three or more than that recti muscles, in two or more recti muscles, then the anterior segment circulation gets compromised, leading to the ischemia of the anterior segment. So, we have to be always cautious when we are operating on more than two recti muscles.
Very good. Excellent answer, because the older patients tend to have comorbidities, which already affects the circulation. Remember, the anterior segment circulation comes through the recti. It comes along with the recti. And here, already one muscle is transected, so gone. And so then if you had a superior rectus tightness, then you have had to bring the two horizontal muscles down, what kind of procedure would you have thought of for the good thing here the SR was not tight, but what would you have thought of to recess the superior rectus? What technique would you have used?
Modified Nishida, ma'am, without compromising the anterior circulation.
Right, that is a very good thought. You can do an inferior modified Nishida, but what else can you do to the SR? If the SR is tight, you have to recess the SR.
Yes, ma'am, definitely recess the SR.
Pardon?
We have, if the superior rectus is tight, then we have to recess the tight muscle first.
Right. So yeah, you can do a combination of SR recession along with the modified Nishida. That's a good plan. You can also, if you have if you have the training, you can do a superior rectus ciliary vessel sparing procedure as well. That is something to remember. And I would even encourage you as a fellow to occasionally try it out, even when it's not required. The reason is you will then know how to do a ciliary vessel sparing, and you will know how to use it when you need it. Okay. And for the postgraduate, ciliary vessel sparing is where you do not cut the muscle, you dissect and take out, like a vascular surgeon, you take out the vessels and dissect them out. And without transecting them, you do the rest of the surgery on the muscle itself. So that is called ciliary vessel sparing procedure. Let me just quickly see if I have any other. Yeah. So this patient is going to need a lot of counseling even before you start. You have to talk about postoperative prisms, and you have to talk about relearning mobility. Can you go to the post picture, the after surgery picture? Yeah, the one just before. Yeah, if you look at this, the depression has improved, but it's still -2. So,
Yes,
and
ma'am.
like it's likely to improve it because transpositions, this is immediate post-operative within only a week. But with time, it continues to improve. And the reason the depression is your very, very important gaze is because it's the functional gaze. It's the gaze for reading. It's the gaze for looking at your mobile phone. It's your gaze for walking down the stairs. It is, and if once you're presbyopic like me, it is absolutely an essential gaze, as important as the primary gaze. So whenever you're managing patients, strabismus patients, the two gazes that you should all the time keep in mind is the primary gaze and down gaze. Okay, so that's a very, very important lesson. So one last question to you before you go to the next thing. So if it was, you find whatever reason everything is scarred in here and you're not able to, when you're scared to bring the muscles down to do a transposition, anything else you can offer the patient to alleviate the diplopia, especially in down gaze?
Apart from prism glasses, ma'am.
Yeah, this is again theoretical. I've only done it on one patient. You can do a Fardens on the opposite inferior rectus, the other eye. Because remember again, postgraduates, what is important is that the ductions need to be matched. If it's only when one eye is moving more and the other eye is not moving much, is all the diplopia, double vision is happening. If both eyes are equal, and what do you do for that? Suppose this is restricted and not going down, or this is paralyzed and not going down. You go and put a posterior fixation suture in this eye, the other eye, and make sure they are matched, they are even. Then the patient won't have diplopia. Remember, we are not going to, it's not about making the eye move more and make it beautiful and all that. It's about alleviating double vision. So sometimes you may have to operate on the other eye. One last question is for you. Can you explain to the postgraduates what you meant by augmentation? I know you mentioned it 8 millimeters. Can you just explain to them what is augmentation?
So, ma'am, by horizontal rectus transposition, we are basically shifting the vector force in the direction of the paratic muscle. And then we do augmentation at 8 mm by bringing the both lateral one-third of both the muscle together, and then fixing it to the sclera. By that, we are basically shifting uh, the pulley towards the direction of the paratic muscle, basically increasing the action.
Right. So yeah, so you change as much of the vector force as possible. And for that you use, and what kind of suture would you use, doctor, for that?
Proline sutures, basically, we need more strength.
Right. So you need to use a non-absorbable suture, right? So because if you kind of mess it up, you also need to be able to take it down. So what kind of sutures are normally used, postgraduate? Can anybody answer for this normal squint surgery, regular squint surgery? What suture is used?
Micro suture. Lactin.
Okay, polygalactin. Good. That's good. Okay, let's move on, which is an absorbable suture, by the way. Let us move on to the next case. A very, very beautifully managed case. Let's move on to the next one.
I have a question. This patient, if he wants to have further surgery, as you said, can we try contralateral inferior rectus recession with Parakkal, or as you suggested, because he still has 6 prisms hypertropia, it's going to 18 prisms in the downways. So what would be the ideal plan to do a contralateral inferior rectus surgery as you suggested?
Yeah. Or you can also explore doing a Scott's procedure. I've done
This
just
is
one. Yeah, on the other.
Yes.
There are no clear tables for the Scott's procedure, which is the only bummer. But you can do a Scott's procedure. And the nice thing about that in this particular patient is you could possibly do it adjustable. Because
just to add, Tasaraki was also done to this patient along with the squint surgery because to address the ocular surface concerns, because he had corneal anesthesia and lack of thalamus. So we did a tasotherapy.
Right.
Dr. Marian is here. She's a primary surgeon. Marian, would you like to add anything to this case?
Neena, yeah, it was a very tough case. Like, combined both restrictive and paralytic element comes in orbital fracture. As you know, it's very, very tough to manage. But still, this facial palsy we managed with the muscle transfer also, but still he had some residual lag of due to multiple reasons, because there is a lower lid contracture also, because as you know, he had multiple infections. So there was an element of lid element also contributing to lung ophthalmos apart from the paralytic element. Hopefully it will recover. I think, I mean, over a period of 1 year, it should recover. That's what I feel. Okay, thank you.
I just wanted to, hello, Marian. I just wanted to add here that
Yeah,
Dr.
yes, ma'am.
No, I was just going to say Dr. Marian's teacher, Dr. Bipasha and myself, when we were in Sankara Nethralaya, were very, very big, what do you say, supporters for wearing a helmet. If we catch anybody without a helmet,
Yeah.
we give them hell. So this is a poster child. This patient is a poster child for anybody who contemplates getting on a two-wheeler without a helmet. Okay. So, I mean, this could have been a bad accident as well, but which I don't know the details. But please, postgraduates, at least you guys, people who you know, ensure that they wear a helmet. It'll be less patience for Marianne, but that's okay. We'll deal with that.
Okay.
Very well managed, Marianne. Very beautifully managed.
Yeah, thank you so much. Yeah, thank you so much.
So our second case is also a young male who sustained a road traffic accident, post which he had orbital fluid fracture repair with titanium mesh elsewhere, and he presented a worsening of the vertical binocular diplopia after the procedure. So his preoperative CT scan, which was done elsewhere, showed the fracture floor of the right orbit with protrusion of the contents into the right maxillary sinus, suggestive of an inferior blowout with bony fragments abutting the inferior rectus muscle. So when he presented to us, he was 60 present diameters of right hypertropia, which was increasing in the right case as well as in the left tilt. So we knew that we are dealing with a case of right inferior rectus palsy again. He also had a normal head posture of chin down, right tilt, and right face turn. We went ahead and did a force duction test for him, which was negative, and force generation test for inferior rectus was moderately positive. The patient was not accepting any results due to highly variable diplopia with head posture. So we went ahead and did a repeat CT scan, which was suggesting edema in the inferior rectus, and the mesh was like in situ, properly covering the flow defect. So we thought of giving a short course of oral steroids to this patient, after which his diplopia in the primary case definitely improved, but he still was 18 present diopters of right hypertropia in the down case, along with -1 depression limitation in the down. This is the diplopia charting. This is the patient's view, which is showing uncrossed diplopia in all the cases, and it's increasing in the right case and down case. So we did a repeat FDT, which was negative for depression and superior rectus, and FGT was moderately positive. Hence, the patient was planned for inferior rectus ligation. So this is the video of intraoperative video of inferior rectus ligation. Using conjunctival limbal incision, inferior rectus was identified. It was hooked, and the inferior rectus was then cleared of all its attachment, including the check ligaments and the intermuscular septum. It was then secured via absorbable 6-0 mitral sutures at the insert, at the 4 mm mark from the insertion. And then we used muscle to sclera to muscle technique. That is, first bite will be taken over the muscle, belly of the muscle. And the second bite will be on the sclera at the insertion. This is the second bite on the sclera. And then we'll bring our third bite back to the muscle. Similar procedure was repeated on the other side as well. The second bite on the sclera at the insertion. And the third bite goes on the muscle back again. And instead of cutting the muscle like we do in dissection, we just fold the muscle on itself. So it's a less traumatic procedure. And then it will be secured to the sclera via these sutures only. And then the tire was closed using 80 micro sutures. The patient did well post-operatively. His down gaze, we can see in the right eye, has also improved. And he did not have any diplopia in the down gaze. He was a merchant navy aspirant, so he wanted his down gaze to improve. That is why we went ahead with this fixation procedure. So my take-home messages from the presentation will be that we have to rule out mixed mechanism strabismus in posterior orbital fractures. Once the restriction is relieved, the paralytic comment surfaces and hypertrophy are in worsen. So we have to counsel the patient to prevent post-surgical surprises.
Very good case again, Dr. Trisha, Dr. Neena, and very nicely managed. Good outcomes. You can tell the inferior rectus function really improved. I have a question which for you, Dr. Trisha. While you were showing the video where the check ligaments were getting cleared and to get the inferior rectus ready for the plication, what is the most important structure that you have to clear, that you have to nibble? What is the most structure there for any inferior rectus surgery? These are the lower lid retractors, right? So the way you identify the lower lid retractors is they'll be going from the inferior rectus to kind of to the lid margin. You can see them as little white filiform, little tissues. And those need to be nibbled, or those need to be, excised, cut during the surgery. Why is that important? I think you did. Yeah.
So the lid changes if we don't properly dissect them.
What changes? Sorry?
Post-operative lid changes.
Absolutely. The post-operative lid changes. One of the commonest side effects of inferior rectus surgery is lower lid retraction. If you do not, because if you do not resect the inferior rectus with the lower lid retractors, as the IR goes down in recession, it takes the lid also with it. And so you will, some patients they come back and they don't like the cosmetic, outcome at all. So this is something that you can easily take care while you're doing any IR surgery. Yeah, great. I don't think I have any more comments for this. I think this was very beautifully managed and well done. I think that's just about time for the other case. Sorry, I've taken too much of your time. Yeah, that's.
I just want to add that the second case came to us after the orbital surgery. The surgery was done well, the restriction was relieved, and then when he came back, he only had an edema of the inferior rectus, which was built upon MRI. So that is why he improved significantly with the steroids themselves.
Yes.
So yeah, that was a difference.
That was good thing. That was good thinking. So it's important. The take home is also the important take home message is that you should re-image at every stage. Sometimes we tend to be a little cavalier, or sometimes we want to cut cost for the patient. We say, oh yeah, the first anyway it was imaged and yeah, it looks good. But before you undertake your surgery, the strabismus surgery, you have to re-image the patient to know what things are, what's going on. This case beautifully demonstrates that. Yeah. Congrats, Neena, beautifully managed cases.
Thank you, ma'am. It's a teamwork. I'm so happy to have Marian, with me, because it's a teamwork in the end. A lot of people are involved in the whole process.
Yes.
So we go on to the next case. It's a short presentation on a child who came to us with night vision, who was brought with complaints of night vision difficulty. Dr. Bhuvana, our primary TNP student, will be presenting it.
Good morning, all. Today, I'll be presenting the case of a 4-year-old male child who was presented to us by his parents, who had noticed that the child had difficulty in seeing at night and also was watching TV at close proximity for the past 1 year. There is no history of photophobia, difficulty in distinguishing between colors, no history of hearing loss, obesity, polydactyly, renal dysfunction, and there is no history of drug intake and any nutritional deficiency. There is no significant ocular history. Coming to the family history, there is no similar complaints in other members of the family, and there is no consanguinity. The birth and developmental history was normal, which then was recorded using Snellen's chart, and the best corrected visual acuity was 6.986 in both the eyes. The color vision using Ishihara plate, the right eye was recorded at 16:121, which improved to 21:121 with red filter. The left eye 21:121. Moving on to the ocular examination, the head posture was normal. There is no facial asymmetry. The child was orthophonic and had good stereopsis. The anterior segment examination was within normal limits. Moving on to the fundus, this is the color fundus photograph of both eyes. Shows clear media, normal optic disc emphasis, and there are extensive chorioretinal atrophic patches along the vascular arteries. Next, here is the optos retinal imaging and the fundus autofluorescence of the right eye, which shows reduced autofluorescence in the mid-peripheral retina, which corresponds to the chorioretinal atrophic patches seen in the optos image. Similar findings are also noted in the left eye. Next, OCT was done, and here is the spectral OCT scan, line scan, which is centered over the fovea. It shows that the vitreoretinal interface appears to be normal. The foveal contour is maintained. Also, all layers of the retina are well delineated, and the ellipsoid zone is continuous and intact. Wide field scan through the area of lesion, there is increase in the thickness of the retina. So there is a loss of the normal retinal architecture, and the outer and the inner retinal layers are indistinguishable. So the ellipsoid zone interruption can be noted. So to further evaluate the functional status of the retina, what is the best next investigation to be done? So we proceeded with a full field electroretinogram. So first I discussed how a normal full field electroretinogram looks like. So there are two phases, the dark adaptation and the light adaptation phase. So first we can see that in a normal FFERG, there are two waves. The first is the A wave, which is a negative, which is an initial negative wave, which represents the photoreceptors. And then there is the B wave, which is a subsequent positive wave, which represents the bipolar and the molar cell activity. So first in the D flash, that is 0.01 candelas per meter square. Normally, a minimal A wave and a prominent B wave is seen. Whereas in the bright flash, that is 3.0 and 10 candelas per meter square, a prominent A and B wave is seen. And the height of the A wave will increase with increase in the intensity of light. Whereas in the dark adaptation, normally a sharp A wave and a sharp B wave is seen. And in 30 Hertz cone flicker, which represents a pure cone function, normally regular high frequency responses are seen. Moving on to the ERG of our patient, we can see that in the dark adaptation, there is no distinguishable wave seen, hence the scotopic response of the child was not recordable. And in the light adapted phase, there is markedly reduced amplitude of the waves seen. The 30 Hertz flicker ERG looks abnormal and severely attenuated. So then we did an S-cone ERG. Here we can see that there is higher amplitude wave of the S-cone compared to the low and medium wavelength cone. So that is definitely an S-cone mediated response is higher. So a genetic analysis was done, which identified a mutation in the NRL gene axon 2, which was compound heterozygous variant, and it was suggestive of enhanced S-cone syndrome. So in this case, the electrophysiology guided the diagnosis. The subsequent confirmation at the molecular level was done with the help of genetic analysis, and diagnosis of enhanced S-cone syndrome was made.
Can you tell something about enhanced S-cone syndrome? You would have read about it.
So in enhanced S-cone syndrome, the NRL gene is responsible for the growth development. So it helps in the differentiation of cone. So here in the enhanced S-cone syndrome, when there is mutation of the S-cone, when there is mutation of the NRL gene, the growth development does not happen, and also there is undifferential enhancement of cones, and there is less M and L cones in the retina level.
As the name says, enhanced S cone syndrome. So you have mainly more of S cones, not much of L and M, that is the medium and the long waving. And also the rods are also not well differentiated. So when when the rods are not differentiated, what will you expect?
Night blindness.
Night blindness. So that's exactly the symptom the child has. And they present very early, usually in the first decade. And can you correlate that with the other findings also? Like you show the fundus photo. So where do you have the maximum changes on the fundus photo?
Maximum changes are seen along the vascular artery.
Or mid periphery. There is a maximum concentration of the rods.
5 degree around the fovea.
Maximum. With cones are
Mid periphery.
yes. So that is why the phenotypical changes are also you are seeing in the mid periphery. And in the OCT. Again, it is sections through that involved area which you're not able to differentiate any cells. And EZ is gone and the entire retinal layers are undifferentiated. So basically, it's predominantly the ecology of the. And also, even the cones, you have mainly the S cones because during development, it is S cones that is expressed first. So that is developing, but the other two are affected. So kind of you are able to understand what is happening in this patient. If the child is old enough and can do a feeds, again the field loss will be corresponding to the same. But I think this patient has a little more advanced damage. That is why, like in the full field DRG, the entire rod responses and clone responses are affected. What is the prognosis?
Not very good.
Actually, it is good. They present very early, but it is not a very progressive eye blindness. What else can you think of in this presentation? In this kind of findings?
Atypical
Yes, we should think of it because any patient presenting with night blindness, we should think of the RP. What are the differences? Why do you say it is not different?
optic disc. See, optic disc is not seen. Also, there is no attenuation of vessels. And the body spicules, which is seen normally retinitis pigmentosa is not seen.
The clinical picture, it's not matching. And again, like full field ERG, it's not able to differentiate, but because you did an S-cone ERG, that really picked up the predominance of the S-cones. Any other condition which can be confused with this? Actually, what did we think of when we first saw the patient? What was our first provisional diagnosis?
Gyrate atrophy.
Why did we think of gyrate? And why it is not gyrate? What is the difference? Go to the fundus. You have an idea of how the gyrate looks like? Yeah.
And the mid periphery.
In gyrate, it will be more towards the periphery with a very typical scalloped margins. And it is important to differentiate that because when we do anything for gyrate atrophy, is there any treatment possible? What is gyrate atrophy due to? Fellows?
Or retina aminotransferase enzyme.
So is there any way to confirm your diagnosis? Any blood test? You can look into the ornithine levels
Yes.
and you can give dietary supplementation. So this is different because it is more towards the mid periphery, which is not the classical presentation for gyrate. But then I came to give across a case report where another patient is that was reported in American AJF case reports. They also diagnosed as gyrate. For 30 years, the diagnosis was gyrate. Then they changed the diagnosis. So it's very well possible that you can get confused between the two conditions.
Can I ask a question?
Yes, ma'am. Yes.
Is that Dr. Lekha who's chairing? Is that Dr. Lekha?
Yes.
Yeah, okay. I just wanted to say hello. And Doctor, can you go to the early slides where you talk about the history and just explain or ask why you asked all that negative history? Yeah. What is
Yes.
each one of this? Why did you ask for each one of this? What were you thinking of?
I was also thinking of asking the same to the PGs. Yeah, that
Yeah.
was a good point. Showed up.
Yeah. Please ask to the PGs, doctor.
Why each of this is relevant.
So the history of photophobia and the color vision defect was asked to rule out any form dysphoria. And hearing loss seen in atypical retinitis pigmentosa Usher syndrome, and obesity, polydactyly, and also the renal dysfunction is seen in quarter within simony status. The drug intake and nutritional deficiency.
Will present with what other they'll have. What is our ocular finding in particular? Because for everyone to know, you have obesity, polydactyly, what is a ocular finding? They'll have night blindness.
Night blindness.
Yeah, so that is again one of the differential diagnoses. Yes. Then
And the drug intake and nutritional deficiency, vitamin A deficiency.
yes, chronic intake is and renal dysfunction. Okay. So that's why this negative history is also important. And another thing which I forgot to mention earlier is usually in enhanced response syndrome, there will be either a large systolic macular edema kind of picture or foveal slices or peripheral retinal slices, which is not there in our patient. But we don't know whether it can develop in the future. And I don't know that OCT through the mid-peripheral part of the retina, it's like thickened and with some gaps in between. Whether it is kind of going to develop into a slices later on, we don't know. But that's again one important differentiating feature between a typical RP and the enhanced response syndrome. You won't get such large slices in an RP. You get CNE, but here you get very significant slices. That's one important differentiating.
But I think this appearance is very classic. So this appearance of response is not classic. But this kind of appearance, you should think about
Appearance and location.
yeah. So there's a wide phenotype presentation for enhanced response. I was reading about it. In the IGO, they have an article from SM. So they have written that you can have scalloped appearance, you can have subretinal fibrosis, cystic formation, schistous-like areas. So probably it's not the same in every patient. Same how you right? So I mean, even we are seeing. I mean, though I've heard about enhanced response, this is the first time. So it's like one of the patients we are actually confirming it, and and that's why I wanted to have to present this case so that we can think of this when anybody presents to us with night vision difficulty and this sort of larger picture.
I have one more question. My question is, it's a question, Dr. Lekha, perhaps. Do Escone syndromes also, when they present maybe a little later, do they have pigmentary changes? And we don't see that too much here, is it because of the early presentation?
Yes. The most common is in the first decade, but they can present later, and that has been reported also. Again, pigmentary changes are seen. You get atrophic areas with the variable degrees of pigmentation. I think it also depends on the causative gene. Like here, it was NLP, but the most common gene involved is NR2E3. So depending on which gene, the phenotype can vary. In fact, the majority of cases are due to NR2E3. That is some neural receptor to subfamily E and member 3. This is NLP. NLP is also reported, but the more common one is the NR2E3. And another.
This is very good poster material for the next AIOC. It's very, very nicely worked up patient. Just a suggestion.
Thank you. And thank you for joining for the class. You're a wonderful teacher, and it was a privilege for us to listen to you. Thank you.
Thank you so much.
Thank you, Dr. MS. It was a pleasure, as always, to listen to you and take very good take-home points. Anybody wants to add anything? Anybody in the who have joined online who would like to ask any questions?
There's one question. When you use stereopsis for the very first case, stereopsis as a swim for the very first case, where was that done?
Screen case.
Yeah, very first. Relative.
The screen case, just to know whether he had, he was able to have any binocular vision for near, because he was troubled by diplopia, to assess his near vision difficulty.
And the popular,
We routinely do stereopsis for all patients, so it gives us an added information that if he doesn't have good stereopsis, his near vision is also quality of vision is bad.
Yeah, it's a part of complete workup in strabismus. And if a patient has good stereopsis, one should just run away. So the opposite is also true. You didn't expect good stereopsis in this patient because he had diplopia, I agree. But it is an essential part of workup and gives us a nice baseline from which to work.
Questions. I'd like to conclude. Thank you, everybody, for joining us. And thank you, Dr. MS, once again. And thank you, Dr. Lekha, for joining me.
Thank you for having me. And this has been it's a great pleasure. I'm happy to do more sessions in the future as well, if you think this was useful. Thanks, Neena. Okay, bye.